All righty, good evening, everyone. We're going to get started here in just a few moments, about 30 seconds here, and give an opportunity for the last few people to get on board here. What we're going to do tonight is the lost presentation, the one that I did not present while I was with you all in Dallas. But was on the curriculum, and so I figured we can cover it here in the webinar, and then get this covered for the CE credits that were promised, as well as having hopefully an interesting discussion tonight about the treatment of ailing implants and what our options are. And so, with that in mind, I'm going to flip over to the PowerPoint presentation, and Ashley is running technology for us, so if there's any issues, hopefully she can get it resolved for us. Ashley, how do I flip this over to the...
Share your screen.
Okay, good. Excellent. All right, so let's get started here. You know, I titled this "The Realities of Treating Ailing Implants and Does Anything Really Work?" because we know that this is an area that we struggle with in practice because there's so much that's not known and there's so much that's not predictable. And I want to speak tonight on two levels with my colleagues. One level is to really explore what we know and what we don't know about ailing implants and the treatment of ailing implants. And then also understand that I'm sharing this information with you on how I teach it to my local dental community. And from a marketing standpoint, I had mentioned to you all that I really believe that ailing implants are not as much a problem for us as periodontists as much as they are an opportunity for us to separate ourselves from the rest of the dental community as the experts in dental implants. No one likes to deal with ailing implants. It can be a very frustrating task and an unpredictable task. But this is really the area where the rest of the dental community is not a fan of involving themselves and indulging into the science of ailing implants. But this is where we, as the periodontal specialists, can cut through the white noise and really let the dental community know, as well as the public at large, that when all else fails, it's the periodontist who you want to see. And so the undertone in this presentation, I'm going to fast forward through some slides that might not pertain to us as periodontists from an interest standpoint, but understand the message is what I'm giving to my local community, both to the restorative doctors, other specialists, as well as to dental hygienists. And we'll interject a little bit as we go along. So with that, let's get started. And Ashley, for some reason, that's not forwarding now. Is it because of the video?
Turn on. Try
Yeah.
one more time.
No, it's beeping, but it's not forwarding. I don't want to have to do that the whole night. Okay, I think it might be going now. Good. All right. So this is Rachel. And the danger in getting in front of an audience as periodontists is that we always want to show the dramatic work that we can accomplish for our patients. And this is really the reward that we all seek as periodontists, to take a young lady like this who had a terminal dentition and be able to do all the things that we do in the form of bone grafting and dental implants and be able to really transform a patient's life. And Rachel's a wonderful patient, but she's a young woman who now has 2 arches of implants. And what does the future hold for her? And what's the predictability of the future hold for her in peri-implant health? And so we have to remember that long-term, we look as periodontists at the success for implants. It's not 1 year, it's not 3 years, it's not 5 years, but hopefully we're looking at 20, 30 years, especially for the young periodontists who are placing implants now. You're gonna have to see these patients through. And at the conclusion, towards the end half of this presentation tonight, I'm gonna share with you some of my experiences for patients that I've seen over the years. And there's gonna be some folks on the call tonight that probably can show 30 plus years of long-term peri-implant follow-up. But we have to live with these things, and what can we share with our patients in terms of what can they expect in the future with their implants? So what happens when things change over time? When we see inflammation, when we see bone loss, soft tissue loss, the accumulation of biological factors, how do we respond? And so when we put a presentation together on implant complications, I think we could divide it into number one, diagnostic complications, number two, surgical complications, number three, prosthetic complications, and number four, peri-implant maintenance complications. And that's really where I want to focus tonight, is on the long-term maintenance. We're not going to talk about broken screws and broken frameworks tonight. We're going to talk about what we deal with, which is long-term peri-implant bone loss, soft tissue loss, inflammation, and the things that condemn our implants. So your patient asks you, how successful are dental implants? And your answer is probably something like this. Well, studies range from 90 to 99%, and many are in the 96 to 98% success range. And in our practice, we are very selective in our cases and really stack the odds in favor of our patients. So we really see that 98% success rate for the implants that we place. And that's very similar to an answer that I frequently give when patients ask about what they can expect for their implants, but we're talking about integration rates. But what's the reality of long-term success? And maybe the better question would be, if the patient asks us, what are the chances I'm going to have a problem with my implant over time? And for the sake of this conversation, if the patient knew how to ask, what's the probability that I might experience peri-implant mucositis or peri-implantitis over time? And studies suggest that possibly upwards of 50% of all implants will show signs of peri-implant disease. And that's a statistic that we probably don't share too willingly with our patients, but one that is truthful. That if they have an implant like this woman, Rachel, at 35 years old, what's the likelihood that she's going to experience a problem, a peri-implant problem, with one or more of those implants by the time she hits 60, 65 years old? That's 30 years from now. It's very likely. So what do you do when we experience these problems? What happens when we see in our practice bleeding on probing? We see inflamed tissues. And more importantly, what are we teaching the dental community about this particular slide? How do we educate the community to respond to inflammatory signs around our implants? What is the first step? What's the second step? How do we proceed? And so in preparing this presentation, I looked at two of the authoritative texts on dental implant complications, the first one being by Stu Fromm and the second one by Mish. And I looked through the chapters on dental implant complications dedicated to peri-implant disease. And interestingly enough, 21 pages in Stu Fromm's text, representing about 4% of the entire text, were dedicated to peri-implant disease. And I said, well, if upwards of 50% of patients are going to experience some level of peri-implant disease, why is so little dedicated to this text? And then we look at the latest publication, the Mish text on avoiding complications in oral implantology. He dedicated 50 pages, or 5.8%, so quite a bit more, but still representing less than 6%. And so why is so little dedicated to the topic of peri-implant disease when we talk about implant complications? And hopefully by the end of the talk here tonight, we'll be able to put that together and understand maybe a little bit of why that is. So the objectives tonight are to identify peri-implant health and disease, understand the possible etiologies of peri-implant disease, and then review the non-surgical and surgical options. And the undertone again is, how do we share this with our dental community? And feel free to use any of these things that we're talking about tonight for your own use in your own communities. So the first thing I always do is I educate my hygienists in our study clubs, our restorative community, and beyond about probing around implants. And this is really important to understand. We kind of quiz them, is it similar to probing around natural teeth? Is it different? Can it, does it vary based on the anatomy over time, or maybe I just don't care? And so we spend quite a bit of time, especially my hygienists love this particular diagram, and I've shown it probably 20 times over the past 10 years, comparing the attachment apparatus of natural teeth compared to implants, because if they can understand the histology around implants, then they can understand what they're looking at. And many of you have probably seen referrals that come in because there's a pocket around an implant, and then you look at it and it's an implant that you placed maybe 3, 4, 5 years ago, and there is a pocket of 5 millimeters or 6 millimeters maybe, and it's not inflamed, and you're saying, well, that's just the anatomy. And that's the importance of teaching your dental community about the histologic attachment. Also, in terms of a topic when it comes to foreign body impaction or cement sepsis, it's important to understand the anatomy of the peri-implant tissues in order to understand the risks that we have with disease. And so we kind of go through almost like a board question, and all of our hygienists, we had 80 hygienists in one of our recent meetings, and they could all answer this question of, if you were to place a probe into the sulcus, what would you encounter? They say on a natural tooth, it's long junctional epithelium, then they hit the connective tissue attachment, then they hit the osseous crest, and if they were to push further, go into the periodontal ligament, versus understanding that there's no connective tissue attachment, that there's an unpredictable long junctional epithelial attachment around the implant abutment, but no connective tissue attachment is predictable, and therefore there's just a gingival cuff or collar around the implant. And this is pretty obvious when we take off a healing abutment and we can see the table of the implant. And you show this to your dental community, understand there is nothing preventing the penetration of foreign material from the gingival margin to the table of the implant, which is essentially in a bone level implant at the osseous crest. That's a very vulnerable environment, and we have to respect it. So what are the probing recommendations? This is a common question that our hygienists will ask us. And so I teach they can use stainless steel probes. It doesn't have to be plastic or titanium probes. Just be cautious about contamination of the probe from adjacent periodontal pockets. So if you have a patient with active periodontal disease, you don't want to necessarily inoculate the pocket of the peri-implant environment from a contaminated, infected periodontal pocket. So what is the recommendation that I give for probing dental implants? I teach my dental community that bleeding on probing is not as reliable as with implants because of the difference in the attachment apparatus. I recommend a gingival sweep as the best evaluation for inflammation. So similar to the old gingival index. Essentially a 2 to 3 millimeter probe on a gingival sweep. If it bleeds, if there's signs of erythema and edema, then we call that site inflamed and action should be taken. Obtain a baseline of probing depth following the final restoration, and then probe as needed. And as needed means if there's signs of inflammation, then they'd go ahead and probe to compare to baseline. If there's signs of radiographic bone loss, then once again, they should probe and compare to baseline. But it's not necessary. A lot of hygienists in your dental community are probably jamming a probe up into your peri-implant environment on every maintenance appointment. I don't think that's helpful. I think it can cause some issues as well as unhappy patients. So an indicator of problematic peri-implant health would be bleeding on probing, suppuration, increased probing depths, radiographic bone loss, soft tissue loss, and obviously all of the above. So any of those signs are the indicators, the 5 indicators that we teach the dental community. If you see any of those, there's a problem, don't watch it, take action. And we'll talk about the action that we take. Here's another really important topic to teach your dental community. And that is how to read radiographs around your dental implants. And you would think that this is, second nature to all clinicians, but obviously it's not, because there is an infinite number of dental implants styles on the market, and how the bone behaves around each of these different dental implants is different. So we need to teach our dental community about some of the general patterns of bone behavior around the implants so that they can identify when there's a problem or not. Certain implants, if there's remodeling, that would be perfectly acceptable. And if they use that same analysis on another implant style, they would miss the fact that there were early bone changes that should be intercepted. So, this is an example of a 10-year follow-up. I would put this up on the board, and I would have a discussion about, what do they see? Is this normal? Is this a problem? This is an 8-year follow-up looking at bone level implants and how we could have remodeling below the table of the implant, even though it's a platform switched, that we might, over the first 12 to 24 months, see remodeling to the first thread, and it should not be anything beyond that. Also, in terms of clinical evaluation, here's an example of a gingival sweep and how we recommend it. There's no bleeding. This is a healthy peri-implant environment. 10-year follow-up on a patient here. Again, no erythema, no edema. Gingival sweep, no bleeding on probing. This is what they should see. But what happens when you don't see that? If this is your new patient, you had implants placed 10 years ago, there's a gap in the crown restoration with the abutment, there's some bone remodeling, is this a problem or not? Gingival health. And so I'm just going to kind of click through this. So these are the kinds of things that I will go through, looking at bone anatomy, remodeling. Is that normal? Is it not? How do you respond? So what about when it doesn't look right? When we have tissue loss, when we have bone loss, when we have erythema, edema, how do we take action, and what's that decision tree on how we should proceed? And so long-term or late onset peri-implant mucosal and bone complications can be divided into a few categories. Number one, peri-implant mucositis. And again, this is just a simple review for the periodontists that we have here on the call, but I'm giving you the formula of which I communicate with the dental community, both in presentation form, in digitally, in newsletters, and so forth. And so peri-implant mucositis, which is representative of erythema, edema, bleeding on probing, suppuration. And I teach that it's essentially the implant equivalent of gingivitis. That's peri-implant mucositis. Number two, peri-implantitis is all the things of peri-implant mucositis, but involving bone loss. So peri-implantitis is the implant equivalent of periodontitis. And then we have this category of soft and hard tissue loss following integration without the presence of inflammation. And we know that we see this probably more often than we'd like to. And so the best I could give the analogy to our dental community is that it's similar to post-ortho soft and hard tissue loss. And we'll talk a little bit about that tonight as well. And why does this happen, and how can we communicate with our dental community on how to respond? And so what are the etiologies of these disease processes? And again, if we were to make a list, maybe we can have, when it comes to peri-implant disease, there's primary bacterial. So it's a bacterial insult of the peri-implant tissues causing the disease. Foreign body or cement sepsis would be number two. Mucogingival deficiencies, number three. Alveolar bone deficiencies, frequently caused by surgical shortcomings, anatomic problems, etc. Compromised implant position. Maybe you had enough bone, but the implant was not placed within the bony envelope in the most favorable fashion. Biomechanical overload, occlusal factors. Adjacent disease. How often do we see peri-implant problems caused by disease in neighboring teeth? One that I see, unfortunately, is neighboring endodontic infections that track right into our implant sites and cause bone loss around our implants. A lot of times we know that infections follow the path of least resistance, which frequently is right through our surgical sites with our implants. Systemic medical compromises, smoking, medications. And now I just have to move this bar because I cannot see. There we go. Okay, systemic, and then combinations. So very frequently, it's not one single category, but rather the combinations of multiple categories. We're going to focus tonight on really the top three categories here, the primary bacterial, foreign body, and mucogingival deficiencies. So does pure periimplantitis exist? And this was something that was debated. I really enjoyed the history of our academy meetings and other meetings that were explored whether periimplantitis existed. And 15 years ago, that was a hot topic. I think today, as periodontists, we do appreciate and respect the fact that pure periimplantitis does exist and is an independent entity. We can have bacterial insult similar to periodontal disease, where pathogens accumulate, can cause inflammation, ultimately bone destruction. And so, just see it, we do have, okay. So when this is a case that frequently you probably will see that there might be some bleeding on probing and very frequently suppuration around implants. How do we respond? And so this is Mary. This was an implant that I placed back in 2006. She was referred for bleeding on probing and bone loss. And so this is one of the things we could look here on this periapical film and we could see this wide circumferential bone remodeling. But if we really look at it, it seems to be down to about the first thread. And so I always teach our dental community, what is the best film to predict bone loss that's most reproducible? And so here is where the bone looks to be on this radiograph. Is that normal? Is that where this should be? There's the table of the implant comparing where it should be. Is it the best radiograph? And we know it's not, that a vertical bite wing would be a much better radiograph to determine bone levels. And when we do a vertical bite wing, we see that we have a nice crestal cortication of the bone, and actually the bone level looks to be closer to the table of the implant as opposed to the first thread. So very important for reproducibility of bone levels to teach our referral base to take vertical bite wings. And a lot of them don't take vertical bite wings. I learned this one recently, mainly because of digital x-rays, that they don't have a sensor to take a vertical bite wing, so they can't do it. So that's an issue. But when it comes to trying to define where the bone level is, that would be the most advantageous radiograph. So inflammation, bleeding on probing, suppuration, those are the signs with no contributing factors. The diagnosis here, we know would be peri-implant mucositis if there was no bone loss. Sort of the treatment options, let's list them. And many of you are probably doing much of this in your practices, maybe some subgingival chlorhexidine irrigation. So if I had an implant patient that was in our maintenance practice and for the first time we saw some bleeding on probing, we may just start by flushing the peri-implant environment with some chlorhexidine, doing a light debridement, and then following up with that patient 6 weeks later. Scaling, if we suspected that there was bacterial debris in a subgingival environment, maybe some chlorhexidine combined with that, maybe even some subgingival chemotherapeutics like Arrestin. Glycine therapy. And I know down your neck of the woods, Pat Allen is now speaking a lot about glycine therapy. I'm not sure how many of you have started doing this, but the past 6 months, we've been experimenting with glycine. I'll talk about that in a little bit tonight. Laser-assisted peri-implant procedures, which is with the ND-YAG, is probably the most well-described for treatment of peri-implant inflammation, but there are other lasers as well. The Erbium, the BioLase has an implant protocol as well as other lasers. So the usefulness of lasers in treating peri-implant disease. And then ultimately incisional approaches like open flap debridement with surgical detox, open flap debridement with detox and regenerative, or surface modification or stripping of the implant surface combined with any of the surgical approaches. Now, if there was no bone loss, I would probably be hanging in the non-incisional approaches. In this particular case, I opted for laser. So again, I would stay away from incisional approaches if I could, unless there were signs of bone loss, then I'd be maybe a little bit more likely to make incisional approaches. So back to our patient, this is Mary, and this is something that I teach our dental community, how to evaluate edema using the side of the probe and evaluating the indentation of the probe. here doing a sweep. This is more than 3, but just to list the fact that there is excessive bleeding and suppuration for this patient. So then we'll go through what are the treatment options available. In this particular case, I treated the patient with laser because I am a periodontist. By the time the patients come and see me, we're going to do something a little bit more proactive. And so because there's a long-standing implant with pretty excessive inflammation and suppuration, we went with laser therapy. This is a titanium-tipped ultrasonic. I'm showing this early in the presentation because this is the one that I use. This is an Action tip. So I would strongly recommend around your implants to use an implant tip. There's a couple of companies that make them now. This is a Carl Schumacher titanium curette. So we use titanium curettes in our office. Your dental community is going to be very interested in knowing the armamentarium of which to operate around dental implants. This is the 6-month follow-up showing tissue contraction, lack of edema and suppuration. This is the kind of clinical health response that we're looking for. And so that's sort of the flow that we'll go through in decision-making. Glycine therapy, which is the Hugh-Freedy airflow, has come to the forefront in terms of looking at non-surgical options. And glycine, as you know, is an amino acid that can be used to remove the biofilm around natural tooth surfaces as well as implants. And it hooks up to your high-speed handpiece. And it has a high-pressure spray of glycine that you can use to debride the implant surface very gently without really even needing any anesthetic. For the amount of pressure that comes out of here, at first I was really thinking that I was going to need to anesthetize patients, that it would be pretty uncomfortable. But amazingly, this tip can go subgingival, and even with high pressure, patients have had really no issues with tolerating the airflow. So it seems to be a very gentle way to remove the biofilm. I can't give you long-term data because we've only been doing it for 6 months, but I do believe it's worth looking at. There's enough preliminary studies that have shown that it's consistent with inflammatory reduction. We've seen that in 6 months, that patients seem to present with much better health. Will it last beyond 6 months? I can't tell you that yet, but I think we should be the ones looking at this particular intervention. And so here's a patient who presented with a lower implant with inflammation, edema, bleeding. And here is what the airflow glycine spray looks like. And again, a tip is a little plastic tip that you can place subgingival, and that's the way you apply it. This was another case where there was some pink porcelain and there was some marked erythema. It was difficult to gain access for hygiene, so I used the glycine to get under there and really disinfect the subgingival environment. And so we're doing more and more of that. Let's go on and charge forward with Donna, who's 11 years post-placement, and she was referred back for bone loss. And we take a look here, and we have pretty significant remodeling around this implant. This is a Straumann implant that I placed 11 years prior. And on the distal aspect, it looks like we lost bone to the second thread. On the mesial aspect, it looks like we can draw it right about to the first thread, although there seems to be this broad area of remodeling of bone, maybe a crater defect or something along those lines. So we've got inflammation, we've got bleeding on probing, we've got suppuration, we've got bone loss. So the working diagnosis is now periimplantitis. Okay, so what are the treatment options? We go right back to our list, but I would start now with laser. For those of you who have laser incorporated into your practices, that would be my entry-level intervention, would be laser, and then that same list of incisional approaches. But if there's laser, if there's bone loss, I'm probably not doing anything less than laser. And so here is that case, and once again, just showing the edema of the case, and we'll treat this with laser. I'm just going to go forward. This is a 12-month post laser treatment. And again, just looking at radiographic differences here, You could see on the distal aspect, we have much better cortication of the bone, but on the mesial is really the area that seems to have filled in nicely. That broad defect has remodeled quite nicely above the first thread where it was prior. And that was with no incisions, purely with an Nd:YAG laser. So I really do believe, and I know it's a hot topic and one that we love to debate in our Perio Academy, but I will tell you that laser has a place in my practice for treating periodontal disease as well as peri-implant disease for results like this one. Is it my one tool of choice? Absolutely not. It's just another tool in my arsenal. And so we went through the fact that I keep saying no other contributing factors. And you all know what I'm alluding to when I say no other contributing factors. And that's going to bridge and segue us right into number 2, which is foreign body cement sepsis. And this is really a rampant problem, and one that has taken us many years to come to the forefront of how prevalent it actually is. And finally, it's something that we're talking about with regularity, but I'm still amazed at how the general dental community does not realize how epidemic cement sepsis actually is. And the Wilson study is suggestive that 81% of all peri-implant disease may be related to cement retention. And that was with his study back in 2009, looking at sites of peri-implant inflammation and using his endoscope to say how many of those actually they find cement retention subgingival, and 81% of the cases actually had cement retention. That's a major, major issue. And I will tell you that we are not immune from this in our practice. As a matter of fact, we are flooded with cement sepsis cases, not just from cases of implants that I've placed that have been restored in my community, but many, many cases that were placed by other surgeons and restored by clinicians that are outside of my referral base. This is a community-wide problem, and I'm sure that you experience it as well. So how do we teach our dental community about this epidemic, and how do we avoid it? And so part of it is just teaching them to look for it, understand it. And it all starts with that histology of understanding why is cement sepsis. You probably have the same thing as I do, that a lot of your referral-based docs are like, I know that this is a problem, but I'm very, very careful. I will go back after I cement and remove the cement. And I try to teach my docs that if you cement a restoration in a way that requires the removal of cement, you've already lost, because you cannot remove cement subgingivally the way you can around a natural tooth, because there is no connective tissue attachment. And so this is something that we've really gotten out, both again in all of our study clubs, through newsletters, through digital education. I can't emphasize it enough. So teach your dental community how to find cement and how to avoid it, more importantly. This is just a gross cement sepsis problem. You could look on that second molar back there in the corridor, and there's a blob of something back there, and that's actually cement. So it doesn't always look this egregious and this obvious, but there's a lot of sloppy cementation that's happening. And there's a lot of careful cementation that just doesn't understand the dilemma of the histologic attachment. So changing the angle of the radiograph can really help. Again, getting bite wings that can show the cement a little bit better can be helpful. But understanding that radiographs are not 100% in identifying cement, because we know that we can't see cement on buccal and palatal-lingual aspects. Cement sepsis does not discriminate. Some of my most skilled clinicians have had cement sepsis issues. I don't think there's a single office that I've worked with over the past 20 years that has not had a cement sepsis case. So this is not void of any particular clinical ability, other than those who know how to properly cement. And we're going to talk about that in a little bit. So here's a case, January 2012. The case was 10 years old back in 2012 when I saw this patient. These were not my implants. They were placed in another area geographically. The patient moved to our area and was being maintained by her general dentist, and all of a sudden she's got a peri-implant abscess. And if we look carefully, we can see, it's gonna be a little hard to see on that projection, that there's cement on the restoration. And so it's seen across all implant systems, and it's seen over time. So again, teach your community that when you see this, when you see acute edema and erythema, start thinking cement. The first thing that I'll do when I see a case like this is put a mirror to the palate, and if I don't see a screw axis hole, 81% chance that that's going to be a cement sepsis case. Teach your community that cement is a bone killer, that right there is a colony for periodontal pathogens that can infect and ultimately kill our implants. And so here's a case that was placed in 2010. We could look at the bone levels on the left, compare it in 2013. We now have dramatic bone loss, and what we see is cement radiographically. So there it is ahead of time. There's the bone level. We move forward, and we see pretty dramatic bone loss within 3 years, and there's cement all over this case. Cement is a bone killer. Here's the story of Monique. I like this case because we were able to follow Monique long-term, and she's actually coming back in for a long-term follow-up here in the next couple of weeks. But the spirit of Monique's case is that cement sepsis can begin a cycle of peri-implantitis that can be tenacious and resistant to effective treatment. And in Tom Wilson's paper, he talks about if you remove the cement, he saw resolution of the inflammation. And what I'd like to challenge is, in many cases, okay, in many situations, if you remove the cement, that you can get a favorable reduction in inflammation, but not all the time. Sometimes we struggle to battle that inflammation even after the cement is removed. And I believe strongly that it has to do with the fact that we've created that pathologic environment. We've probably now have biofilm into the surface of our implant. And even though you've removed the cement and maybe try to treat the surface of the implant, we're now dealing with an implant that's been assaulted and insulted by microbiology. And so here's Monique in 2002. She lost her lateral incisor. We extracted, grafted, and here she is in 2008 on a 6-year follow-up. Now, I was a young periodontist, and there's things I could look at with this case and critiques. I would have loved to have a shorter clinical crown length. She's got a high smile line, but she's happy with the final result. And there she is in 2008 with a 6-year follow-up. She's got apparently healthy peri-implant tissues. So we're all happy in 2008. Now, Monique cracked the porcelain of her implant in 2011, and a new crown was fabricated. And by February 2012, she presents like this. And so, of course, we take a mirror and we look to the palate and recall that this was a cemented case. And then I interviewed Monique and said, well, what's happened here? I just saw you last year. What's happened? And she said, well, I had the crown redone because the porcelain had cracked. And so it was remade. And so we know that there was a cement event that occurred. So there's no doubt that this was a cement problem. We look radiographically and we could blow this up. And again, I'm not sure if you'll be able to appreciate that, but they're lining the abutment, and the restoration is an area of cement. And not always easy to pick up on, but we teach the dental community to use your software, change the contrast, change the brightness, and we should be able to hopefully pick it up in many cases. So how much cement is really there? And we know, just like most things in periodontics, that if you pick it up on a radiograph, it's probably a lot worse than you actually see it. And how should we attempt to remove it, and what are the risks? And so this was a surgical removal, and although it was very difficult to see the cement on the radiograph, you could see that surgically there's an abundance of cement on the facial aspect, and many of you treat cases like this all the time, and you know the pitfalls that this patient has moving forward. And so there's the cement. We do papilla sparing incisions to try to save the aesthetic profile of the soft tissues because this is a high smile line case. We'll get into a little bit more how I actually do the treatment in surface modification here. And so here she is in January 2013 on 1 year post-op. So at this point in time, things look good and we seem to be happy. She's had a good result. But then she presents in November 2013 with edema, erythema, bleeding on probing, and suppuration. And there's no further cement events. So we said, you know, was this crown removed, re-cemented? No, it wasn't. Everything has been stable. So now we have a surgical removal of the cement and disinfection. It seemed to be okay, but now we have recurrence of the inflammation. What are we going to do at this stage of the ball game? I've already made an incisional approach once. So we're going to do another surgical approach. We're going to try non-surgical interventions. We're going to do laser. And again, because I'm a laser periodontist and I have it in my arsenal, this time I'm going to come back with a laser-assisted approach. And so that was what was done in 2012. And here she is at the conclusion of the procedure. And here she is in October 2014, resolution of inflammation, and you know, things seem to be stable, but there's been a cost. We've lost the distal papilla, and again, in a high smile line case, that's not a great thing. I haven't seen her since this time, and she's supposed to be coming back in. So next time we meet, maybe I can give you the long-term follow-up on that case. But once again, the message that I give to our referral base is that cement sepsis can begin a cycle of tenacious and resistant periimplantitis, that we've now infected the implant surface. So the best way to treat this is to avoid cement sepsis in the long run, right out of the gate. So decision tree: inflammation, bleeding on probing, suppuration, plus or minus bone loss. What do we do? Well, no detectable cement. We know that the working diagnosis was primary periimplantitis. If there's cement detected or suspected, it's seen radiographically or it's detected clinically, then we call it foreign body-induced periimplantitis. It is bacterial in nature. Should we attempt cement removal with an explorer, a scaler, or chlorhexidine flush? I warn my community that this is really tricky business, because you could make it look better for the short term and you may have gotten out some of the cement, but there could still be a whole bunch of cement left subgingivally that can set up a problem for bone loss. I'm nervous about our dental community nursing these cases along, thinking that they did a good job of removing the cement. And then by the time that I see the case, we've lost a lot of bone, and it can create aesthetic issues, functional issues, etc. So I caution on attempting cement removal with an explorer and just trying to flush it. Laser. The nice thing about laser therapy, whether it's an Nd:YAG or an erbium, is it does create some relaxation of the sulcus, so you have a little bit more visibility to get down there and try to visualize what might be happening. And that's why my non-incisional approach for treating cement sepsis would be with a laser. And then, of course, all of the incisional approaches we talked about before. And you guys are down there in Texas, so maybe some of you have an endoscope, and that certainly would be a nifty tool from everything that I've seen to try to remove cement. But it's a whole lot of technology to solve a problem that we shouldn't have in the first place. If there's bone loss, again, I'm thinking surgery. I don't want to mess around. When I say surgery, incisional surgery, if there's bone loss, I'm probably more likely to take a 15 or a 12 to the tissue and get in there and clean it out. Here's Marianne. Marianne is an interesting case. She's referred for bone loss of implant number 13. This is a Straumann implant. And this implant was placed in California in 2002. So I did not place this implant. She moves to my area in Connecticut. She never had issues until recently. Now she's got mild discomfort, some drainage, and her restorative doc refers her for bone loss. Let's blow up the radiograph. So the question in this case is how long before cement caused clinical problems? And so typically it's diagnosed in the range of 4 months to 9 years with an average of 3 years. And that comes out of Wilson's work as well. So that's consistent with what we see in practice, that most of the time it's a few years before we detect that there's cement there in terms of inflammatory response. And sometimes we've got plenty of cases that are 10 years plus before they show any signs of inflammation. I think in some of those delayed cases, actually caused by dislodging of the cement by a pretty adept hygienist. I think probably the cement has been there for a decade or more, and then one day they sense something subgingivally, and they take a scaler or an explorer, and they're able to get to the cement and probably dislodge part of it. And now we've got this loose sequestrum of cement sitting in that peri-implant environment. And that might account for some of the cases where we see these long-term delays. And so if we blow up the radiograph here, we could again see right along the body at the crestal portion of the implant, the cement. And there's the bone levels. Make it a little bit easier. There's the cement. So what are you going to do? How are you going to treat this? Well, for me, again, because there's bone loss here, it's a posterior tooth, and I know we have a little bit more leeway aesthetically, so I'm not going to mess around. This is going to be an incisional case in my hands, and once we've reflected the flap, you can already see the cement. And remember, it's 360 degrees, so we have to debride palatally as well. Again, today, this was back before titanium curettes were available. So today I would use a Carl Schumacher is the brand that I have. There's a few companies that now make the titanium curettes, and I would use a titanium curette. So we get a full appreciation of the osseous defect. We're going to irrigate the area. Now what? We know that this has existed for some time. We've got an infected implant surface. How are we going to debride it? Again, this is before titanium ultrasonic tips were available. And so today I would use an ultrasonic, an Acteon titanium. This is an oscillating titanium brush. And so Straumann makes this oscillating handpiece. Many of you might have this. Salvin also has a rotary titanium brush. I have that as well. So some form of titanium brush scrub. I'm dipping that in EDTA. I want to try to detoxify the surface the best I can. Does it work? I don't know. I'm certainly going to try. We're going to graft this with allograft. So this is freeze-dried bone allograft. I'm going to use a collagen membrane. This is a non-cross-linked trade name on this one. This is a Dynamatrix made out of Keystone, for those of you who'd like to know. And we're going to do the same thing on the palatal aspect. And so we're all looking at this as periodontists and appreciating the fact that this surgery that I've just performed here to try to treat peri-implantitis secondary to cement sepsis is absolutely technically more demanding than the actual placement of the implant itself. So this is a costly procedure, both in terms of time in my hands, in terms of time for the patient to go through this procedure, as well as the cost of doing that procedure. There is a cost to it that's going to approach the cost of placing the implant itself. And I explain to patients that technically this is just as difficult as, and if not more than placing the implant itself. If you have any chance of holding on to it, it's what needs to happen. 1 year follow-up, fortunately, we have excellent resolution of inflammation. There is a cost. Thank goodness this was not like a number 8 or 9 with that high smile line like we saw with Monique. So we now are showing the abutment or the shoulder of the implant, because this is a Straumann tissue level implant. So we don't have a whole lot of options available at this stage of the ball game. Thank goodness it's a posterior tooth. Let's look radiographically how we made out. And so here's the before and after, and we can see the bone fill that, at least radiographically, that we accomplished. On the left side, we were down the second thread on the mesial. Now we are above the first thread on the distal. We were about 1 3/4. And now, once again, we are somewhere above the first thread on the distal aspect. So fortunately, a good ending to the story for that particular patient, but not always predictable. Here's another case. And again, I have a binder filled with these cases of cement sepsis. And so this patient was referred for an infection on implant number 10. And the implants were placed in the UK in 2007. And I found out through the interview that the crowns came off. They were re-cemented several times, but I saw no radiographic evidence of cement. And so I thought that maybe because I was actually presenting a lecture for a regional society on periimplantitis. And to be honest with you, I don't have that many cases of primary periimplantitis. And I thought that finally I found one. Annette was going to be my case where we've proven primary periimplantitis. And there it is, it's bacterial in nature, and we're going to treat it. And so here's her case. And I absolutely went into this case thinking that we were going to treat primary periimplantitis, and we were going to detoxify implant surfaces and see what we could accomplish from a traditional incisional approach. So here's incisions, and I'm just going to show you this case just because it's such a dramatic finding that once we got in there, you could already see what's around the abutments of the teeth, especially number 10 right there, that there is a huge ring of cement that did not show up radiographically, and not just a little bit, but a phenomenal ring of cement. And that's not that uncommon. But again, even with a variety of views radiographically, you could not pick it up. Once again, this is that Acteon titanium tip, which I'll use around implants, less scratching of the implant surface. So just important. So again, it turns out to be a cement sepsis case. Unfortunately, even the 2-year follow-up for this particular patient had a lot of inflammation, as you can see here. So the environment has been set, the stage has been set. We're going to battle with peri-implant inflammation on this patient. We've lost tissue height. Aesthetically, she's not happy. This case is a disaster. So how do we prevent cement sepsis? And this is an important thing to teach your referral base, is that they've got to know their materials. They've got to, because a lot of what's marketed to them as implant cements they can be really detrimental to our implant environment. And so the biggest offender are the resin-based cements, because they're porous. They can collect and harbor biofilm, which can infiltrate the resin. So resin-based cements can really be quite dangerous. They're not water soluble, they're easily colonized, and yet they're the most common marketable implant cement that your restorative base sees. So you've got to teach your referral base that resin-based cements can be a problem if their cases are not cemented properly. The zinc-based cements, the most common one being temp bond, at least they're water soluble, and zinc has antimicrobial properties. So zinc-based cements can be better for long-term peri-implant health. Obviously, the knock against temp bond is its holding strength. And so here's the problem, that a lot of our restorative doctors, the first cementation might be with a zinc-based cement, and they'll do it very carefully. But then if the restoration is lost, they have a patient who comes into their office and reports a loose crown and they want it re-cemented, and the patient's upset. They're not happy that their crown came loose. Like, why did this crown come loose? And your restorative doctor doesn't have a whole lot of time in their schedule to deal with this. So they're rushed, and they may even put the patient in the hands of their assistant, and they grab a resin-based cement. We're going to get a better bomb this time. And they do a quick cementation job. And that's what I found is the danger appointment, is that re-cementation appointment is a high-risk appointment. And you've got to talk to your referral base about that quite candidly and say that that second cementation is the one that can get us in trouble. So if you have a patient that comes in, you're better off re-cementing with temp bond if you don't have the time to do it properly with resin and then have the patient come back at a later date. Polycarboxylate cements can corrode titanium, just be careful with those. But this is the cementation technique as described by Wadhwani and Pinheiro. They've got some great papers on this, on how to create a chairside copy abutment. We've done hands-on programs with our referral base, and I strongly recommend that if your restorative doctors are going to cement cases, they should know how to do a chairside copy abutment. There are lots of labs like Atlantis and others that can create a secondary abutment for you. I would venture to guess that most docs are not purchasing that secondary abutment to pre-cement. And so if they're not, they don't have to. They can do a chairside copy abutment. And basically what you're seeing here in diagram 1, the crown is lined with Teflon tape, and then the abutment is placed into the crown to basically push that Teflon tape into the crown, and now you have basically the luting space necessary for their cement. In step 3, they insert any kind of like a bite registration. There's a blue mousse bite registration material, and kind of dapple it up like an ice cream cone. So they have a handle, disengage it once it's set. And in diagram number 4, they have a chairside copy abutment. And that's an exact replica of their abutment. And so now they can remove the Teflon tape, they could cement the case onto the chairside copy abutment. You can see in 5 that the cement is extruded. So rather than extruding subgingivally, it's extruding in your hand. They can wipe it away with a cotton pellet or other gauze or whatever they like to use, and then deliver it to the mouth safely in order to cement that with no extrusion of excess cement. And that is the way our restorative community should be cementing cases. If they're not doing this, then unfortunately, they are extruding cement and risking the long-term health of your patient. And so that, again, is described by Pinheiro in a 2009 paper. I have and Wadhwani as well. I have the reference right there for you. Moving on, screw retain restorations. Now this is really, the pendulum has swung, and obviously the early implant cases were done with screw retain restorations. Then everything went towards cements because it represented much of what our dental community is comfortable with, which is crown and bridge, cementable crown and bridge. But we have really pushed our referral base back to screw retain restorations. I will tell you that personally, and probably a lot of the docs on this can have experienced similar things, that without a doubt, when I see cement cases come back to me, the rate of which we have peri-implant inflammation, even if it's just push on those gingival tissues and see a little suppuration come up around the sulcus, it's not uncommon. It happens an awful lot. Take the same referral doctor, the same restorative doctor, and have them do screw retain restorations, and these cases are coming back with perfect gingival health. I honestly believe that exactly what Tom Wilson had reported in 2009, that 81% of the time that we see peri-implant inflammation, that it's caused by the toxicity of cements. This is an epidemic that we as periodontists should really be out in the forefront educating the dental community and getting our hands wrapped around this. And so I'm looking at my own responsibility in how I provide surgical procedures for my referral base to allow them to do screw retain restorations, that I have to make sure I'm doing my part to set them up for success, that they're able to do a screw retain restoration, and then it's up to them to choose to restore it that way. To share the story of Sharon with you, this is a 20-year history. And so I share Sharon with you because she was one of my first patients in private practice. I graduated from University of Texas, San Antonio in 1998. I went into practice in Connecticut as a budding periodontist who just wanted to conquer the world. And Sharon comes in and she's got advanced bone loss with molar number 3. And so I thought I'd apply all of my regenerative techniques with Sharon to try to save this tooth. She had a long history of periodontal disease, It wasn't just in the upper right. She had molar disease in the upper left as well. And unfortunately, a year later, the tooth abscessed. And I said, Sharon, don't panic. We've got titanium implants. Let's remove this tooth and graft the site and place an implant. And Sharon probably asked me back in 1999, well, what's the success rate of dental implants? And I probably told Sharon, oh, it's probably, 98%. That's what the studies say. And in my hands, I'm going to try to stack the odds in favor of your success. And so it's going to be about 98% success. And so Sharon said, okay, great. We extract the tooth. We preserve the site. We come back. We got a nice ridge to work with. And here we are ready for implant placement. And so in 1999, I placed this transgingival or tissue level implant. It's a Straumann. And I thought life was good. And I could already look at this radiograph today with my 20 years of experience and know that I've already set the stage for problems for Sharon, and many of you are seeing it yourselves already. And so here she is in 1999. I placed the post for my restorative doctor, and I sent the case back to be restored. Simple crown and bridge. Life is good. Take a little impression basket. Take your impression. I thought I was doing a good job. Now the problem, of course, is that the implant level at the tissue margin has left my restorative doctor with very little running room for emergence profile. And this is a large first molar. So I have really handicapped my restorative doctor. It's got to figure out a way to fill this gap with a very short running room. And so here is a 1999 photograph. The restorative doctor has done his best to try to fill this huge gap with this restoration. And we look radiographically, it's a squared off restoration, almost coming straight off the platform of the implant horizontally to try to fill that massive gap. And so we've already got an issue. And if you look really closely, what do you see underneath the restoration? And to be honest with you, I'm not even sure if in 1999 I saw that on that radiograph. I went back, I don't have the notes from 1999, and I can't recall if I had treated anything regarding cement sepsis, but there's definitely a problem there. So 7 years later, in 2006, Sharon comes back, and now she's got bone loss, she's got inflammation. Her dentist says something's not right with this implant. And we look at radiographically, she's lost massive amounts of bone and approaching maybe the apical third thread on the distal aspect, and maybe about the fourth thread from the apex on the mesial. And so there's the outline of the bone loss. And there again, I see some kind of opacity. So there's still something up there underneath the restoration. Etiology, is it primary periimplantitis? Is it cement sepsis? Is it iatrogenic periimplantitis caused by restorative contours that were created by me and the way that I placed this implant? Or is it all of the above? And probably it is all of the above. And so what are we going to do? Well, I said to Sharon, with the amount of bone loss that you've had, and of course I wasn't happy in retrospect looking at the placement of this implant, I said, maybe we should just remove it. And Sharon says to me, no, let's not remove it. She says, you told me 98% success rate. Can you save it? I said, it's not predictable, but we can try. And so at that time, should we do non-surgical, scaling, antimicrobial, glycine if it was today, laser therapy? I didn't start laser until 2008. It hadn't even been recommended on implants yet. And so we opted for an incisional approach. So osseous regeneration, try to do an apically positioned flap to give a little more access to clean. And so here's some surgical photos from 2006, again, prior to titanium tipped ultrasonics. As you try to debride the site, I actually use in the right-hand slide photo there is EDTA. I think that was Pref Gel, EDTA. So trying to detoxify the implant surface. And then we grafted with allograft and closed it up. And so if you look at these radiographs on your left, you'll see the 2006 in December prior to treatment. And now we're looking at January 2009. So we got a few years later. and we've got some decent bone fill, and things seem to be okay. Things are going well, we thought, all right? But the one thing I'll point out there, you could see, I've circled for you on the right-hand photograph, that now there is a restoration on the mesial of the second molar. So now, why was that? Did she have caries there? Well, actually, no. That was a resin-bonded restoration that the restorative doctor did to try to close this gap that Sharon was still complaining about, that she didn't like. She was packing food in there, and so he thought he was doing a good thing by adding a restoration there. And so now she comes back in 2011, general practitioner number 2. Okay, so it's not the same restorative doctor that she was originally seeing. This is now a different practitioner and someone who I don't work with. So it wasn't like I got a phone call that we're going to redo the restoration. And I see her in 2011. There's definitely new restoration, and I like the contours. The contours seem to be more favorable, and it seems to fill the proximal area, and she seems to be happier. But there's something that's cause of concern for me, and that's that I know the anatomy of a Straumann implant, and this was a wide table implant, and I can't see the wide table anywhere. So something's fishy. Bone levels looked okay at that point. There's the new restoration. But by 2014, there's a problem. She's now seeing the 3rd general practitioner. And so he says, hey, there's bleeding, there's suppuration, there's bone loss. And so we take a look here. And in May of 2014, she's got another large osseous defect on the mesial of this implant. So there's the contour right there. Etiology and treatment options. Well, I said to Sharon at this point, you know, it's another insult. Should we just take this implant out and redo it again? And of course, Sharon said, no, I don't want to do that. You told me 98%. Can't you try to save this implant for me? And, you know, I said, well, we can do some surgery again and try to clean it out again and see what's going on up there. And so here are the photographs from 2014. And you can see on the left-hand side that the restoration goes down onto the implant body. And so what general practitioner number 2 had done was modified the Straumann implant body, had gotten rid of the table and prepared onto the body the implant to give greater running room for the implant, but he forever modified this implant. So now we're stuck with it, and there's nothing we could ever do to try to re-restore this. We're gonna have to try to live with it. And so I tried to recontour some of the overhangs on the implant. Then we treated it the way we have done in the past with detoxifying. That's the oscillating titanium brush. We grafted it. Okay, there's the titanium brush. There's some EDTA that we're scrubbing, some allograft, close. There's that restoration. You're seeing it again. And so there she is in October of 2014. So now, where is she today? And so here she is in 2018. I just saw her last month. 19 years later, after having this implant placed, there she is. She's got that same restoration that was made by general practitioner number 2 that was prepared onto the implant body. She has excellent fill of the bone after the second insult of bone loss. She now has an amalgam restoration, replacing the old resin restoration on the mesial and now occlusal of molar number 2. And so 19 years later, she still has this implant, 98% success. So if she asked the question, you know, what's the success rate of implants, 98 would be accurate. But if she said, what are the chances that I'm gonna have to go through 2 more additional surgeries, 2 more restorations, a restoration of my back tooth in order to hold on to this implant, I'm not sure that she would have opted for the dental implant back at that time. But there's Sharon. And of course, she still has a large gap between the 2 molars, but the implant tissues are healthy. There's been a huge cost to this case. And obviously, it's been a great learning experience for me, 19 years following Sharon in the life of her implant. It's given me a perspective to make sure that my role in implant dentistry is to be thinking out 20 years. Like, what is this going to look like in 20 years? How confident am I in what I'm offering this patient? And what do I need to do to stack the odds of success in favor of our patient? And so there she is with a gingival sweep. Tissues are healthy, 20-year history. There's at its worst on the left, and there she is today. So she's, I dare not say happy that she still has the implant, but she's pleased that we've been able to maintain it. Okay. So is that the end of the story? I don't know. I'll tell you in another 10 years as we follow Sharon moving forward. So mucogingival deficiency, I'm going to go through this quickly, but this is an area that I really think that we can distinguish ourselves, because who else in the dental community is going to pay attention to the mucogingival foundation around dental implants? And how important is it? Do we need attached gingiva for health? And we sit there and you go through the history of our periodontal literature, and there's been a lot of debate. A lot of the early studies said that it wasn't necessary, but the design of those studies didn't really look at the long-term health. They were looking at overdentures. And I would even say in my clinical experience that keratinized tissue has only helped patients even in overdenture situations. But a lot of, this is a patient of mine who lacked an attached band of tissue. I placed it in 2010. 6 years later, things look good. But is that always the case? Is keratinized tissue necessary? And some of the newer studies are suggesting that inflammation rates are higher and bone loss is higher when attached to, compared to those cases that have attached gingiva. And so here's a case of mine. Patient presents pain, edema, erythema, and suppuration on implant 10. And so if we look at that, and this is an overdenture case, if you look at this a little bit closer, we notice that there's no attached gingiva around this case. But why is implant number 10 the only implant where the patient's having problems? The patient has a nice thick biotype around all the other implants. And we look at bone remodeling around that particular implant. Another case, how often we see these cases with the shallow vestibules, mucosal margins, losing soft tissue height, bone remodeling, losing bone height. Okay, so mucogingival issues, is it related to active periodontal disease? Here's a case, loss of tissue height without the signs of inflammation. So it doesn't always have to be accompanied by inflammation. We've seen those cases. Case looked great when the case was complete, but now 5 years, 10 years later, we're showing abutments. And if you look at those cases, how many of them have mucosal margins? So how important is biotype? Having a good hard tissue foundation, having the appropriate soft tissue foundation in maintaining long-term stability of soft and hard tissue around our implants. We are the experts when it comes to building the foundation. If we teach the dental community the importance of this, we stand to gain from it in our marketing, because they're going to view us as the experts in long-term health. Your other disciplines that place implants are not capable of doing the type of soft tissue grafting in most parts of the country and most of our communities. Most OMS, endodontists, even prosthodontists are not doing soft tissue surgery the way we do it, and to the expertise that we perform it. So we need to educate the dental community on the importance of the soft tissue foundation. Great marketing angle for that. Loss of tissue height with signs of inflammation, because it's sore to remove plaque, brush, and floss. So patients stay away from those areas, accumulating bacterial debris, more prone to peri-implant inflammation. And so here's a 9-year post-placement case that I placed these 2 implants. Patient is referred back 9 years later, losing tissue height. What's the etiology? There's no inflammation. Why is this patient losing soft tissue and bone? Well, look, there's the mucogingival junction, has nice attached tissue around the natural teeth, but we lose it around the implants. And so I teach our community, how do you look for your mucogingival junction? We all know this, horizontal probe technique. Teach them how to look at that. Here was where the case was when I completed it. You have the bone level is the table of the implants, looks great. And here's the patient in 2016, 9 years later. Let's blow it up. There's the bone level. So how should we treat the case? Well, it's not inflammatory, right? So why am I going to do laser or incisional or chlorhexidine or glycine or whatever? There's no inflammation. So do what we know how to do and do a gingival augmentation. So I treated this with a large free gingival graft, created a nice band of attached tissue. Okay, this is 18 months post-surgery. And interestingly enough, I can only tell you this anecdotally, and some of you may experience the same things, but when I find these cases that have had bone remodeling, crestal bone remodeling, that I suspect are secondary to mucogingival defects, and I've treated the mucogingival defect and done nothing else, I seem to find that the crestal bone changes are advantageous. So if you look at the mesial implant, and again, this is only anecdotal, these are not standardized radiographs, we all know that, but certainly when I look at the radiograph, on the left-hand side, the crestal bone level on the distal aspect of the mesial implant is about down to the second thread, and now on the right side, we're about above the first thread, and this is not uncommon that we see some of the increased cortication. Here's one, mucogingival defect, bone loss, not surprising, no vestibule. What's the fix for this? It's a free gingival graft. This is what we do. So this case, I didn't see the appreciation in bone changes, but here's one that I did. 2014, this patient presented 4 years post-op. It was placed by an oral surgeon in my area. Patient is sore, doesn't like to brush around the area, it bleeds, gets referred. There's the mucogingival junction. We can look at that situation as periodontists. We know exactly what happened on that case. Those were vertical incisions, and probably during the site preparation of this case, my guess is that the surgeon had placed a couple of vertical incisions and tried to advance the mucosa over the ridge, and it was never replaced prior to placement. So now we got a mucosal margin. So imagine being able to take this message to your dental community. Like, we have to avoid this. Like, this is all about surgical design and using our surgical expertise to prevent this kind of result, because just because the thing is stuck in bone doesn't mean that the patient is going to be free of problems. And this is a problem for that general dentist. And so we can help the dentist avoid having to experience this with their patients. And so we have bone remodeling on this implant, down a couple of threads. How are we going to treat it? Well, obviously I debrided it, cleaned it up. Once the tissues were healthier, we did a free gingival graft. I'm not going to bore you with that. There's the free gingival graft. And there she is 3 years post-op. Again, it's nothing fancy. We can all do a free gingival graft. But if we look at bone levels, again, we have increased crestal cortication. Looks like we've gained some bone height on the threads from the pre-op. 2017, again, this is opportunity. For me, I don't dread implant complications. This is complete opportunity to separate myself from the crowd with our referral base. And so an oral surgeon had sent this patient back to the restorative doctor and said, ready to restore. And it was one of those situations where, restorative doc had sent it off for an emergency extraction, never saw the patient again until they had an implant. And the patient comes back and says, I'm ready for my crown. And, the general dentist said, I didn't even know you had the implant. But fortunately, I credit the general dentist for saying something doesn't look right here, had gone back to the surgeon and said, something's not right with this case. And the surgeon said, it's fine, just go ahead and restore it. So the general dentist sent the case to me. And so in the initial exam appointment, I pulled out a sequestrum of bone from that little linear opening and that you can see in the left-hand photograph. And we all know that, again, this was a vertical incision that was made at the time of extraction over the root surface of the bicuspid. And unfortunately, the buccal plate became necrotic, lost the buccal plate. That's what we're now measuring, about a 5-millimeter dimension of buccal plate that's been lost. And so the dentist knew that this was a problem. We look radiographically, we see a lot of particulate. This is not a great looking case. And I basically said to the general dentist, no matter what I do for you on this case, this implant will never be right. So I honestly think we should start over. And obviously that's not a great thing to have to deal with as a patient. It's not a great thing for us to have to deal with as a dental community. But I'd rather get this patient started right. The dentist obviously was bought in and said, no, I don't want to invest my time and money on a restoration that's not going to work. And so we surgically intervened. There's mucogingival issues on this case. There's a mucogingival cleft in the distal of 20. There's a missing buccal plate. There's, and also the coronal implant position. I showed you Sharon's case. Well, look at this case. This is a bone level implant that's essentially placed at the CEJ of the adjacent teeth. No running room whatsoever. That's a major problem for the restorative doctor. And so the suggestion was, let's just get rid of it. So I flapped it July of 17, and you could see I could shoot a probe right down. So there was no bone integrated on this implant anyway. And so reverse it out with a reversal tool. This is a Nobel reversal tool. Many of you probably have seen that or used that. That's my tool of choice for just about any implant. This great little gadget. And now we've got a huge defect that we're going to graft with allograft, and we're going to use a collagen membrane and close. But we've only solved one problem, and that's the implant placement position, the lack of integration. We're left with a large mucogingival defect. So this, again, is where we can intervene and bring all of our tools to the table, do a gingival augmentation, and start building keratinized tissue. I'm going to fast forward from the CBCT, and there's the patient prior to placement of the implant. We've got a nice broad band of keratinized tissue. I mean, these are the kinds of cases that are important for your dental community to see how we address dental implant complications. Let's not get there in the first place. This is an erbium laser that I'm using to do a little plasty. You can see the irregularity in the keratinized tissue. So we're just going to flatten that and get that looking better. Nice broad ridge. That's the way a grafted ridge should look. Placement of implant. No surprises. But again, teaching the dental community the proper position of the implant. Learn from my lessons from the past, placing our implants much deeper in molar areas to give our restorative doctors much more running room for final restoration. You can see on the left, if we were to try to restore that, we'd have a mushroom top shaped restoration, leaving large gaps proximally, food impaction issues, unhappy patients, you know, as opposed to being able to have the running room for proper emergence profile and filling those interproximal gaps. So I no longer place my implants at the crestal bone level, even if I fought hard on preservation procedures to preserve that bony crest. I'm sinking it about 2 millimeters subcrestal and giving that running room to my restorative doctor. So you look here, this is a 4 millimeter healing abutment. So imagine in the original placement, we could see the bone, the table, the restorative table of the implant at the gingival crest. Here, a 4 millimeter healing abutment is buried. So I've gained approximately 4 millimeters of running room for my restorative doctor. Last case of the night, and then we're going to finish up. All right. And this just speaks to the combinations of complex issues that we can encounter. And this was Donna, who I placed her implants 14 years ago for an overdenture, and a bar was made and clips were made. And Donna, by her own admission, disappeared off the face of the earth. She hadn't seen a dentist in many years, and she presented to my office with pain of her implants, and she's like, I don't think things are right, and this is the way she looks. So this is her denture, which has got an entire petri dish of bacterial colonization. Again, she hasn't seen anyone in many, many years. We look at her radiographs, and she's lost massive amounts of bone, approaching 75, 80% on the first implant on the lower left. She's lost almost 100% of the bone level on the third implant, and somewhere in between on the second and fourth. And so her chief complaint is pain in the lower right. We'll call that implant number 3, numbering it from left to right. and you can see how angry the tissue is. So what's the etiology? Is it bacterial? Is it mucogingival? You know, I say I'd make an argument that it's primary bacterial. I would certainly say at this stage of the ball game, it's mucogingival in nature. Alveolar bone, is it possible that there was no bone there? I worried about that. I mean, how did I set this case up? Number 5, compromised implant position. I don't know, maybe it was. I can't recall 14 years ago. Biomechanical overload. This denture has never been relined. It has never been adjusted. The occlusion, who the heck knows? Maybe we're overloading these implants, and she's not the healthiest person in the world. She's got a lot of things in her medical history. Could there be some medical compromise? Clearly, this is a combination, complex case. I went back and found my binder of 35 millimeter slides, and I had this photograph which showed at the time I had done this case with some 3 Imtex as a provisional support for her prosthesis while we allowed the implants to heal. And I looked there, and I'm pretty pleased with what I see. Looked like the implants were well placed. Looked like she had plenty of bone. Looks like she had keratinized tissue at that point in time. So these are all problems that happened over the past 14 years. What are the treatment options? Debride and scaling, I don't know if that's going to be sufficient. These things are pretty well infected. Surgical debridement, surface disinfection, will that even work? Extraction, explantation of all 4 of them or some of them, I don't know. And so I removed the bar in this particular case at the day of surgery, and we decided we were going to at least flap them and see what we were going to do. I put some fixture mounts on, and I basically took a finger and I just kind of flicked them, and the first implant stuck. And so there was some level of integration of the first implant. The third implant popped right out, and so I removed the third implant. And so the goal is going to be, maybe we can try to treat the 2 implants that don't have the fixture mounts right now, so implant 2 and 4, and maybe we'd hold on to implant number 1 with a healing abutment just to provide some support. And so there's the removal, and you can see the level of contamination of this implant number 3. And if that's what we see there, we know that we're dealing with similar types of contamination on the other implants. And so we flap the case, and you can see that all the threads are absolutely filled with bacterial debris. So how on earth are we going to detoxify and disinfect that predictably? And in this case, thank goodness it's not an aesthetic case. This is not implants 8, 9 with a high smile line. These are functional implants for functional stability. So we want to try, and by the way, Donna, real nice patient, but she's financially strapped. I want to redo this case and regraft it and create something with a fixed hybrid prosthesis for her. But she could not do that financially. So she cried and she begged me to help her hold on, which is why we're doing this. So how can I hopefully help this woman try to hold on to her implants, to hold on to her lower denture? I'm not sure that any of my disinfection techniques, I'm confident that they're going to work. So I started using the titanium ultrasonic tip to get in between the threads of the implant and remove it. And I could see that this is just a nightmare. I cannot do this predictably. And so we use the titanium brushes. Again, I'm just not feeling the warm and fuzzies. And so Frank Schwartz, we've seen him present for our academy, for the AO, and a lot of his root surface modification of the implant surface. And so I opted for that particular approach here to strip the threads of the exposed parts of the implants and then disinfect the surface from there. So if I could remove the threads in the implant surface, I have a much better shot of disinfecting the implant. And so here we are. Once I've stripped the implant threads, I'm disinfecting with EDTA. I'm going to try to impact the mucogingival deficiencies with gingival augmentation. And so here is Donna at 2 weeks, obviously looking kind of angry and uncomfortable. Here she is a few weeks after that. And here she is throughout healing. So she's got her prosthesis with 2 locator. We switched her over from the bar to 2 locator attachments, put a healing abutment on the 3rd implant, and got her into the hands of a good restorative doc. And here she is after a few months. And here she is on 1 year follow-up. And so at 1 year, fortunately, she's got healthy peri-implant tissues. She's got a nice vestibule around her implants. Again, thank goodness this is not an aesthetic zone because it would be entirely unacceptable. But we've been able to salvage a situation that looked pretty dire and almost hopeless. And so here's a little closer view on each side of the 3 implants. And there's her prosthesis now clean, and she's on a maintenance program. And so that's where Donna started from, and that's where she is today. So she's come a long way in terms of compliance, but a tough situation where we have to pull out all of the tools in our arsenal in order to get the success that we want. And so going back to our original message, which was why only 4 to 6% represented in these complications books, not surprisingly, it probably has everything to do that the other 95% of these texts are dedicated to avoiding these problems in the diagnosis phase and in the surgical phase, as well as in the prosthetic phase. And a lot of the things that we have problems with over 5, 10, 15, 20 plus years are things that we impact in the setup of the case. And that's the message that we have to take to our referral base, that together we can collaborate and have better long-term predictability. That's why we need each other. So long-term implant success requires precision collaboration today at the highest level. There's nothing that your restorative docs want less than complications with the work that they do. They need us. We just got to keep sending that message and what we could bring to the table for our teams. And so with that, I want to thank you all. It's 8 o'clock, and that was my goal, to get you all out of here at 8 o'clock Eastern time. If you have any questions, there'll be a link I'll send. When I send out the link for the recording of this, I'll give an email. You could shoot me any questions. It's been a lot of fun. I enjoyed coming down and spending the day with you in Dallas, and again this evening. I hope you're all well, and have a great night. Bye-bye.